I'll start with an introduction. I'm Jill Lacy. I'm a medical oncologist here at Smilow Cancer Center, and I have a practice focused on GI cancers with a particular interest in pancreatic cancer. I also have the privilege of serving as the co-leader of the Smilow Cancer Center Pancreatic Cancer Program with my colleague, Dr. Mandar Mazumdar, who directs a very large lab-based research program that is exclusively focused on pancreatic cancer. So we've organized the Smilow Shares event on pancreas cancer tonight purposefully to coincide with World Pancreatic Cancer Day. And this day is actually a global event. It's being observed around the globe in many nations as we speak. It's held annually on the third Thursday in November, which is today, for about the past 10 years. And the purpose of this day really is to shine a spotlight on the pancreatic cancer problem, to educate patients and families about this disease, but also importantly, raise awareness to others in hopes of really promoting support for research and support for our patients and families. We know that there's really an urgent need to invest in this problem, and that really comes through research and in supporting our patients and families. And what we've learned from other cancers is that awareness, public awareness and advocacy matters. That often leads to dramatic increases in funding for research, and that has led to dramatic improvements in outcomes in many cancers. So we're going to spend the evening, the next about hour and a half, focused on pancreas cancer. You're going to hear from some of our faculty here at Smilow, from very different disciplines, but all very focused on this problem of pancreatic cancer and are involved in caring for these patients. We hope to leave plenty of time for questions at the end. We really want there to be some dialogue. We're here to answer any questions that you may have. Please put them in the chat. As we go along, if there's time and the clock allows, we'll take a couple of questions to the panelists after their talk, and then we will do a Q&A at the end. So our agenda is shown here with our speakers and their pictures and their roles here in Smilow and the topic that they'll be speaking on. And I'm going to kick things off with just a few introductory remarks about pancreas cancer. So I'll start with a basic question. What is pancreas cancer? What is pancreatic cancer? And when people talk about pancreatic cancer, they learn of a friend or a family member who's been diagnosed with pancreatic cancer. We're usually referring to the most common type of cancer that arises in the pancreas. And more precisely, this is pancreatic ductal adenocarcinoma, often abbreviated and referred to as PDAC. And PDACs arise from the cells that line the ducts of the pancreas and represent about 90% of all cancers arising in the pancreas. And again, when people talk about pancreas cancer, they're usually referring to PDACs, although there are other tumors that arise in the pancreas. So in this cartoon here, this is illustrated. So here's the pancreas, this big orange organ. It makes digestive enzymes, and those are carried through this ductal system from the pancreas into the intestine to help with digestion. And pancreatic cancer, or PDACs, arise in the cells that line these ducts. The next most common tumor or cancer that arises in the pancreas is something called pancreatic neuroendocrine tumor, or PNET. And these tumors arise in these little blue islands of cells called pancreatic islets. The pancreatic islets produce hormones such as insulin and other hormones. And this is really a very different disease from PDACs, different biology, natural history, prognosis, and treatment. PNETs were made somewhat famous by Steve Jobs. He was diagnosed with PNET. So pancreatic cancer has been in the news in the last few weeks when the NIH released on October 27th its annual report to the nation on the status of cancer. And there was a lot of excitement about this report because overall it was extremely positive. Cancer death rates in the United States are coming down in adults and children in every racial and ethnic group over the last 5 to 7 years, and in many cases dramatically so, such as in lung cancer. This report, however, highlighted specifically pancreatic cancer, as it stands out as one of the few cancer types where the incidence is on the rise, and along with that, death rates are on the rise. So this has been identified as really a public health issue, which is important.
Hey, Jill.
Yes.
We're not seeing your slides.
Oh my goodness, why didn't you stop me?
I just did.
Wow, why not? Thanks. All right. Try again.
There we go.
Oh, better. I am very sorry. All right. So to recap, we talked about what pancreatic cancer is. And we're going to be talking primarily tonight about pancreatic ductal cancer. And here's the cartoon that you didn't get to see with the pancreas, the pancreatic ducts, and where these tumors arise, and then the islets where the PNETs arise. And here's the upshot from the annual report to the nation on the status of cancer, where it was specifically highlighted that pancreas cancer remains a challenge. And these are the statistics which tell the story. There are only about 60,000 cases per year in the United States, so it's actually not a common cancer. There are over 250,000 cases of breast cancer and nearly as many of lung cancer. But it's the third leading cause of cancer-related deaths, and that is projected to move into second place within the next year or two. The 5-year survival remains discouraging at just about 10 to 11%. And what's very problematic in this disease is that 80% of patients, when they present, already have advanced disease, advanced stages, and are incurable. And what was highlighted in the annual report, not only these statistics, but that the incidence is increasing at a rate of about 1% per year. We don't really understand the reasons behind that. And along with that, the death rate is going up as well. However, the news is not all discouraging. There has been progress in pancreatic cancer. Since 2000, the 5-year survival, as shown in this graphic here, has doubled from 5% to 10 to 11%. Now, that's not good enough, but it certainly is progress. The 1-year survival has nearly doubled from about 24, 25% to over 40%. And this is attributed not to a major transformative breakthrough in treatment, as we've seen in lung cancer or melanoma with immunotherapy, but really to incremental steps in improving the outcomes for these patients related to earlier diagnosis. We have better imaging, we have better surgical and endoscopic techniques, which we'll hear about tonight from some of our speakers, which has improved survival. We certainly have more effective chemotherapy in the last 10 years, which we'll hear about, which has improved survival, and advances in supportive care. And all of these so-called baby steps in the aggregate have led to these improvements in outcome. So why is this disease so challenging, so tough? And there really, I think, are 3 major reasons that we've identified. So one is prevention. There really are no known interventions to prevent pancreatic cancer in the vast majority of patients. Early detection has been problematic. We do not have an easy, accurate screening test for pancreas cancer as we have, say, in breast cancer, lung cancer, colon cancer, prostate cancer, cervical cancer. And then the biology of this disease, as we've learned in recent years, is incredibly complex and is creating challenges. The tumor tends to grow in an infiltrative pattern around blood vessels, so even when it hasn't spread, it often is unresectable or inoperable. It tends to metastasize early before it's visible on imaging. So again, patients are often advanced stage at diagnosis, or there's a high propensity to recur after surgery. This is a cancer that grows in a scar-like material or stroma that is a protective shield or armor that interferes with therapeutics getting into the tumor microenvironment. And this contributes to the fact that this is a tumor that is invisible to the immune system and is resistant to the current FDA-approved immunotherapeutic agents that have been so important in the advances in other cancers. And then we've learned a tremendous amount about the genetics of this disease. We know a lot about the mutations that cause pancreas cancer. We've identified some of the driver mutations that are very important, but these have largely remained undruggable. We don't have good drugs, and therefore the precision medicine approach to treating cancer, which has been so important in some other cancers, has been elusive in pancreatic cancer. But I would say that we are at an inflection point in this disease. I do think that the future is hopeful and things will change. And that is in large part due to the dramatic increases in funding for research and drug development that we've seen for pancreas cancer. And that is due to increasing awareness from the efforts of our patients, family members, friends, and advocacy groups. And that research is really what has led to this really rapid evolution in our understanding of the complex biology of pancreas cancer. And through that research, I think we are all very confident that it will lead to prevention and early detection strategies and new and better treatments for patients who are ultimately diagnosed. So with that, I'm going to turn now to our panelists. We're going to start with Dr. Justin Persico. So Dr. Persico is one of our colleagues, also a medical oncologist at Smilow and an assistant professor of medicine in the section of medical oncology at Yale School of Medicine. He is focused on GI cancers and pancreatic cancer. He has a very active practice at the Trumbull and Fairfield Smilow centers in Fairfield County, and he also serves there as the medical director of those centers. And as a medical oncologist, Dr. Persico is going to be speaking to us tonight about the medical management of pancreatic cancer.
Okay, thank you, Dr. Lacy. So I will get my presentation up here. Thank you, everybody who's joined this presentation tonight. Okay, so before I move forward, everybody can see that.
Yeah.
Okay, perfect.
Yes, you're good.
So thank you for the introduction. Yes, I am a medical oncologist, primarily working out of the Trumbull Fairfield Care Center, which I'm the medical director there as well. And my practice is focused on GI oncology, including pancreatic cancer. And I was tasked tonight with discussing the medical management of pancreatic cancer. And I am not going to repeat some of the things Dr. Lacy already mentioned in terms of some of the epidemiology and stuff for pancreatic cancer, other than to highlight a couple of the key things I think she mentioned, which is that while it's a rarer form of cancer, only accounting for about 3% of all cancers, it has a high mortality rate. It's highly lethal with a general overall 5-year survival only estimated at 11%, which is something we direly need to improve on. This is because of the fact that I'm going to highlight this in a couple slides from now. Most cancers are diagnosed at an advanced stage or they're incurable. That is what really drives that mortality rate. I will put a plug in for Smilow Shares episode that was earlier this week. Dr. Lacy mentioned that the main type of pancreatic cancer, the most common, is what we call the pancreatic ductal adenocarcinomas. Neuroendocrine carcinomas are a different type of pancreatic cancer, and there's an excellent program led by Dr. Pamela Kunz earlier this week, so you can find that on the website or on YouTube. And this is just a different way, I think, of looking at some of the data that Dr. Lacy was discussing, where this graph shows the rate of new cases as well as the death rate from pancreatic cancer over the recent decades. And especially over the last 20 years, we've has seen a clear increase in the incidence, the number of cases of pancreatic cancer. The death rate has also increased primarily as a result of that, but you can start to see the curves separating a little bit there, which reflects some of what she mentioned about the improvements in diagnosis and treatment of this disease, but still a lot further to go, of course. I will highlight some of the risk factors for development of pancreatic cancer, and probably the most well-known one is cigarette smoking. There are others that may be not as well known. For example, being obese or having physical inactivity has been linked to increased risk of this disease. Also, diets high in saturated fat, smoked and processed meats are linked as well. Patients with diabetes are at a higher risk of this cancer. Patients with chronic pancreatitis, which is sometimes due to alcohol use, but not always. But also increased alcohol intake is also directly linked to this disease. And then there are the genetic predisposition syndromes. So these are genes that are passed down that can increase the risk of development of pancreatic cancer, among other cancers. And even just having a family history, in particular, having a first-degree relative or having multiple relatives with pancreatic cancer would increase the risk. So how do these patients present to us? Well, some of the most common symptoms are listed here. Asthenia is this feeling of just a general weakness and malaise, loss of strength, and can be a very vague symptom, but can be one of the most common symptoms that this disease presents with. In addition, we often see weight loss, sometimes unexplained, where people have fairly normal appetite, and sometimes it's due to what we call anorexia, which is a loss of appetite. Abdominal pain is very common, typically upper abdominal pain, and some patients will describe a pain in the deep upper abdomen that radiates straight through to the middle of their back. That's a sort of a classic pain syndrome coming from the nerves that surround the pancreas, different than a more common lower back pain that people might experience. Jaundice is another symptom that can be seen, and this picture of the gentleman on the right shows this. This is a yellow color to the skin and eyes caused by increased bilirubin buildup in the blood. It can also cause a very dark color to the urine, almost brown color, as well as if that bilirubin is building up in the blood, then it may not be excreted normally in the stool, and the stools can be a very light color, even white or clay color. Nausea and diarrhea are also fairly commonly seen, and something called steatorrhea, which is an increased amount of fat in the stool due to malabsorption of fat from poor function of the pancreas. And people can describe stools that float in the toilet, or oily film on the stool or in the toilet as well. When a patient presents to clinic, some of the signs that we look for are, of course, the jaundice can be an obvious sign when the patient comes into the exam room. But on a physical exam, we can find things like an enlarged liver, what we call hepatomegaly. Sometimes you can palpate actually a mass, a tumor in the area of the pancreas in the upper abdomen. There is something called Courvoisier's sign, which is from a enlarged and distended gallbladder that can happen because of a blockage coming from the pancreas. Ascites, which is a buildup of fluid in the abdomen, can be seen as well. This causes the abdomen to be distended, sometimes very uncomfortably and firmly. More rarely, but I think important to highlight, we can sometimes see what's called Trousseau syndrome, which is a syndrome of repeated and multiple blood clots, sometimes involving the peripheral veins on the surface, of the skin, but also often involving the deep veins of the body, and this can be a life-threatening syndrome. So after we see a patient, the next steps in evaluation typically include laboratory testing, in particular liver function testing, pancreatic enzyme testing, and some patients will express a marker of pancreatic cancer in their blood, something called a CA19-9. Imaging is the next step. Often ultrasound may be the first thing that's done by the primary care doctor or the emergency room doctor, which can show an abnormality in the pancreas or an abnormality of the liver and gallbladder. But ultimately, CT scan is going to be our best test to identify tumors in the pancreas. And we're typically requesting something called the pancreatic protocol CAT scan, which better focuses on the anatomy of the pancreas, can better delineate where there could be a mass or abnormality and how it relates to the other organs and structures in that area. Once there's a suspicion confirmed here, then additional testing to more closely evaluate and ultimately obtain a biopsy is required. And we're going to hear more about these procedures later on in the presentation, but I'll just mention them here. There's endoscopic procedures like what's called FRCP and EUS. These are basically procedures where the doctor puts a camera down through the esophagus, stomach, and into the small intestine in the area of the pancreas. And can evaluate the ducts that come from the pancreas, the liver, and the gallbladder, even relieve blockages if they are there by opening up the ducts and placing stents, and using an ultrasound internally. EUS stands for endoscopic ultrasound, to get a better characterization of any tumors in the pancreas, the lymph nodes and surrounding tissues, and obtain sometimes better biopsies as well. What an MRCP is actually an MRI test, which is similar in that it can evaluate the ducts from the pancreas, liver, and gallbladder better, but it doesn't allow you to intervene because it's an imaging study, but it's something that sometimes we'll use to diagnose this or determine if some of these other procedures could be necessary or helpful. In selected cases, we may do more advanced testing, for example, something called a PET scan. This is typically used when there's some ambiguity in the other imaging, or there's a question if the cancer has spread and it's not clear from other imaging. It's a type of functional test which highlights metabolically active cells like cancer cells. I guess a bit more rarely, something called a staging laparoscopy is sometimes needed, which is a surgical procedure where they put cameras into the abdomen to directly look at the tumor and the area to see if there's been any spread and determine if there is involvement of adjacent organs and structures. Ultimately, when a patient is diagnosed with pancreatic cancer, we do recommend genetic testing. This is for all patients with this diagnosis, and it's because up to 20% of patients will have a mutation in the known cancer predisposition genes, and there may be recommendations for how to better screen and evaluate those patients as well as their family members. And there can also be treatment implications, as I'll discuss later. So I'm just going to touch a bit on staging. I think we'll hear more about this later in the presentation, but just to give an idea of how we sort of classify pancreas tumors. And the system we use is called the TNM system. T refers to the tumor size and whether it involves any adjacent structures. N refers to whether there could be lymph node involvement. And M stands for the presence of metastases, cancer spread to other organs and other parts of the body. And on the right here, I've included the general percentages of people diagnosed based on their stage. And what I'll highlight here is that it's actually quite rare for patients to be diagnosed at what we would call an early stage, stage 1 or stage 2. Only about 13% of patients are diagnosed at that stage. Most patients are diagnosed at a more advanced stage, stage 3 or stage 4, where the cancer is already spreading. Stage 3 would refer to the involvement of lymph nodes typically. And stage 4 would mean that there are metastases, for example, to the liver or the lung. The picture at the bottom of the slide, I think, is a good visual conception of this. And I highlighted the first two pictures here only to say that these are early stage cancers that are what we would call potentially operable. So they're isolated tumors within the pancreas that do not involve adjacent structures and therefore may be amenable to removal with surgery. The second two pictures here are where the cancer is a bit more advanced and it's starting to involve adjacent structures like the intestine shown here and the blood vessels, the arteries and veins in the area. This is where the cancer may or may not be resectable. Sometimes we'll use the term borderline resectable when it looks like the tumor can be potentially operated on, but the chances of a successful operation may be compromised, and there are ways, and we'll talk about this, to maybe help in that scenario. The last picture, it shows where some of the lymph nodes may be and how they can be involved with the cancer. That's our advanced stage. So what is the role of systemic therapy in the treatment of pancreatic cancer? Well, I would break it down based on the sort of category of the tumor. And these are sort of the big categories that we use when we discuss these cases. So resectable cancers are those, like I said, that are earlier stage that the surgeon looks at and thinks they can remove. The standard of care for a long time was to do an operation as the first treatment for pancreas cancer when it looked like it was resectable, and then to give some treatment after that to try to reduce the risk of the cancer recurring or developing metastases. Time, as I'll talk a little bit about, the strategy has changed a bit where we're starting to use more and more treatments pre-operatively, so before the operation, because studies have shown that this can increase the chances of having a curative resection. So we call an R0, which means there's no residual cancer after surgery. So by giving some treatment first, we can sometimes eradicate microscopic disease that may not have been able to be removed with surgery and improve overall the chances of surviving and being cured of the cancer. This is sometimes done as chemotherapy all before surgery, or sometimes done as chemotherapy both before and after what we call perioperative treatment. For patients who are what we would call borderline resectable, all of the above that I've mentioned is the goal of systemic therapy, but sometimes actually we can make tumors that, or there's a real question about whether they can be removed surgically and convert them into something that more clearly can by actually shrinking the tumor so that it is not as involved with adjacent structures. For example, classically, the big thing we're always looking at the most are the blood vessels in the area. And Dr. Constantine will talk a bit more about that later. For unresectable or metastatic cancers, the role of treatment is a bit different. So with unresectable tumors, treatment with chemotherapy is primarily aimed at preventing the cancer from progressing and getting worse and delaying the metastases that can happen. When the cancer has metastasized, treatment is aimed at trying to limit that and potentially improve symptoms from the sites of metastases or from the primary tumor, and try to maintain or improve, if possible, the patient's quality of life, and ultimately to try to extend the life, because in this situation, unfortunately, the cancer is not curable. So what are the systemic therapies that we use for pancreatic cancer? So this is just an outline. We're going to go into a little bit more detail on each of these, but while we've made some progress in the treatment here, the mainstay of treatment, as Dr. Lacy mentioned in the introduction, is still chemotherapy. Targeted therapies, immunotherapy have been a bit frustrating in terms of getting them to work and finding ones that will work for pancreas cancer, but there have been some advances, which we'll go into now. So when it comes to chemotherapy, I like to group it into sort of three main groups. I mean, really two main group plus what I would call, an extra group. One type of chemotherapy treatment are what we call fluoropyrimidine-based treatments. And these utilize a backbone of a drug like 5-fluorouracil, which the category of that drug is what we call fluoropyrimidine. This is often combined with one or two other chemotherapy drugs to enhance efficacy. And the regimens and the names I've listed here, we combine three different drugs. Typically, we're using another drug called irinotecan, another drug called oxaliplatin for a regimen called FOLFIRINOX. But if we use only one of those drugs with the fluorouracil background, we might call it FOLFOX or FOLFIRI, depending on the combination. These treatments require a central venous access, or what we would call a port, because while the treatment is given in the office initially, there is a continuous portion of the treatment that's given for 46 hours after that. And this is something that we can do via what's called an ambulatory infusion pump so that patients can do this treatment at home. They don't have to be admitted or stay in the hospital for it. This is typically how it's given, and typically these regimens are given every 2 weeks or every 14 days for as many cycles as the oncologist recommends for you, depending on the goal of treatment and whether or not surgery is planned. There is an oral form of fluoropyrimidine called the capecitabine. It's not as commonly used because the oral form does, in general, have a slightly increased toxicity and may be difficult for a lot of pancreatic patients to tolerate, but it is an option that we sometimes use in specific circumstances. The second main group of chemotherapy treatments I would categorize what we call gemcitabine-based treatments. So gemcitabine is kind of one of the original chemotherapy drugs that showed efficacy in pancreatic cancer, but on its own, it's not terribly effective. If you combine it with other drugs, it can definitely enhance the efficacy, particularly with a regimen that combines it with what's called nanoparticle albumin-bound paclitaxel, or Abraxane is the common name. This is a form of the drug paclitaxel where it's bound to a protein called albumin, which seems to enhance its uptake into pancreatic cancer cells and enhance its efficacy. We sometimes combine it with other drugs, as you see here. But the last thing I will highlight is there is this sort of plus category, or this additional drug, which is a little different, called nanoliposomal irinotecan, or Naleri, which is a form of the drug irinotecan being packaged into these microscopic, what are called liposomes, which allows it to remain at therapeutic levels longer in the blood, and has been shown to be more effective against pancreatic cancer than just the regular irinotecan on its own. So some of the novel therapies that we've developed are listed here. And the first group that I'd like to highlight are treatments that can target what's called homologous recombination deficiency. These are patients that typically have what are called BRCA or PALB2 mutations. These mutations cause the cancer to have difficulty repairing its DNA. And a drug like olaparib, or Lynparza as it's commonly known, can further block this pathway, which can lead to catastrophic inability to repair DNA and the cancer cell dying. These treatments are typically used as a maintenance treatment after some initial chemotherapy, but can be used on their own, particularly in later lines when other treatments may not have worked. There are also a group of patients which have deficient, what we call mismatch repair enzymes, or what's called a high tumor mutation burden. And I group these together because they basically both result in increased number of mutations within the cancer, which can enhance the ability of the immune system to recognize these cancer cells as abnormal, as cancer cells. And we can use drugs like pembrolizumab, or commonly known as Keytruda, which enhance the immune effect and try to stimulate the immune system to recognize these foreign cells and attack them in these patients. And it's been used, it's one of the cases where immunotherapy has been shown to be efficacious. There are other targeted agents that can be used for the rare other mutations that we may find on what's called next generation sequencing. So this is testing of the cancer cells where it looks at all the different genes of the cancer and tries to identify abnormal genes that can be targeted with some of the targeted drugs that we have. And these are sort of three main ones I would highlight for these specific mutations, but these are unfortunately rare mutations that we see. So at Yale, we're trying to, of course, advance our treatment of pancreatic cancer. And as a research institution, we have several clinical trials. I've highlighted some here to try to improve on our treatments and improve survival from this disease. Most of these trials, I won't go into detail with each one, but the first four on the list involve trying to combine immunotherapy with other drugs like chemotherapy to see if we can get immunotherapy to be more effective here, because as Dr. Lacy mentioned in introduction, that's been a big advance in many other cancers. And if we could unlock the power of the immune system with some of these combinations to fight the cancer, it would be a big breakthrough for our patients. The last trial involves use of a novel treatment, something called the polyamine inhibitor. So we're also looking at, not just focused on tunnel vision of immunotherapy, but also other novel treatments that are showing some preclinical activity in this disease to try to advance our care. So if you'd like to learn more about these things, I'll highlight first, in terms of research, the main website I've mentioned is the clinicaltrials.gov website, which would include listing the trials that Yale has, but also trials at other cancer centers all throughout the country. And we'd encourage almost all patients with pancreatic cancer at almost any stage to consider participating in a clinical trial. There's also great information at some of the big research foundation websites like the Lustgarten Foundation and the Hirschberg Foundation. In terms of general informational resources, the American Cancer Society and the Pancreatic Cancer Action Network are great resources. And Yale also has its own research page with links to several of these things, but also good general information about pancreatic cancer and its treatment. So with that, I'll give it back to Dr. Lacy to continue the program.
Great. Thanks, Justin. That was a great comprehensive overview. Okay, we are going to now transition to Dr. Thiruvengadam. Dr. Muniraj is a gastroenterologist, and he has a very strong focus and interest in diseases of the pancreas, and in particular pancreatic cancer. Dr. Muniraj is really an integral part of our multidisciplinary team for pancreatic cancer. He really plays a key role in not only diagnosis, but managing many of the complications. I have him on speed dial and work with him very closely. Dr. Muniraj is an associate professor of medicine in the digestive diseases section at the Yale School of Medicine. He also serves as the associate chief of the digestive health program in the Yale New Haven Health System. And he is director of the Yale Center for Pancreatitis and director of advanced endoscopy. So, Dr. Muniraj, the floor is yours.
Thank you, Dr. Lacy. Thank you for the nice introduction. And thank you for all the Smilow leadership for this opportunity. And thank you all for joining at this time of the day. I really appreciate that. Can you see my slides?
Yes, we can.
Perfect.
Oh, great. As Dr. Lacy mentioned, I'm one of the gastroenterologists. I practice advanced endoscopy. In next few slides, I'll show you how we can help with patients with pancreatic cancer with endoscope. Endoscopy has evolved a lot over the past 20, 30 years now. As you all know, like it's a thin camera scope which goes through the mouth into the stomach, and then we can visualize on real time, including the stomach lumen and also outside the stomach lumen. And it's very minimally invasive. Most often we do endoscopies as a day procedure and an outpatient procedure in and out. As I told you, in the past, there used to be no role for endoscopy in pancreatic cancer management. But that has changed a lot in the last 20, 30 years now. Initially, we used this only for diagnosis. And then someone has known cancer already, we use endoscopy to help with staging, so-called scanning around the pancreas. And now we have novel curative treatments too with endoscope, and a lot of palliative methodology with endoscope to ultimately improve the quality of life. As I told you, we used to use FRCP to diagnose pancreatic cancer many years ago. And then, of course, FRCP is used to help with jaundice. I'll show you more about that. And then we got endoscopic ultrasound, which helps for diagnosis and also for staging, and also other modalities like endoscopic stenting and biopsy, and also nowadays to help with radiation therapy and a lot of new therapies using endoscopic ultrasound. We'll see how I can explain you in the next few minutes now. This is the typical endoscopy room at Yale. As you can see, there's multiple monitors around, and we can do X-ray procedures and ultrasound procedure at the same time. And we're really fortunate to have a sophisticated endoscopy unit where we can do novel complex endoscopic procedures as an outpatient minimally invasive method. Pancreas is a deep organ. It's pretty hard to access through skin. In the past, we used to do pancreatic cancer biopsies going through the skin under CT scan. But now with endoscopic ultrasound, you can see that it's just behind the stomach. So it's easily visualized through the stomach wall by scanning through the stomach wall. And we can real time see the pancreas and surrounding structures when we pass this endoscope, which has a ultrasound probe at the tip. As you can see in this cartoon, we can see the pancreas and also all the neighboring structures like bile duct and blood vessels. And that really helps not only to diagnose, but also, like Dr. Persico mentioned about staging, to stage the pancreatic cancer. And as you can see, the tip of the ultrasound scope, how it looks, it has a camera and it has ultrasound end, and also the small port where you can send needle out through this to take samples from the suspected mass if you have. So that we call as fine needle aspiration. And as you can see in this picture, the needle passes through the stomach wall into the pancreatic mass there. And we can take a sample, and also what we can do something called rapid on-site evaluation. And we're pretty fortunate to have a great cytologist and pathologist. This facility is not available all over in all the facilities across the country. So when we take the sample, we stain that right away in real time again, and then look under microscope while the patient is still sedated, and we can look under microscope. Pathologist comes to the endoscopy unit, and we get the diagnosis immediately. And then we call Dr. Lacy and Dr. Kunstman and Persico's team to just proceed with the next steps of the care immediately. So also this method helps to make sure we are at the right target, getting right specimen and immediate diagnosis, as I told you. And also with this method, there is something called fine needle biopsy, that is taking a core biopsy, getting a real tissue. Now we are not talking about looking under a microscope for cells alone, but we are looking at histology, actual tissue architecture. And that helps in many different ways, like you heard about different mutations, and different mutations have targeted therapies. So that really helps, and we do genomic testing on the samples we take from the fine needle biopsy. And also Dr. Lacy was pointing out about how the pancreatic cancer can have a capsule around. Sometimes it makes the cancer resistant for the chemotherapy penetration. So we have something called organoids. We grow these cells in a petri dish outside and test the chemortherapy medication first, if that works or not, before administering to the patient. This is a new avenue and still coming up now. So I want to point out this particular patient who had a prostate cancer screening CAT scan, and a small mass was seen in the CT scan right here. As you can see, it's pretty subtle and no symptoms at all. No abdominal pain, no symptoms what Justin was showing. So then we did ultrasound endoscopy, and you can see that the ultrasound scope goes into the stomach, and then through the stomach wall, we can scan and find a small, very small pancreatic mass there. And this is what, like stage 1 and stage 2, what Dr. Persico was pointing out, pretty hard to find at this stage. But if we're able to diagnose, and that has a really good prognosis. This patient had Whipple surgeries many years ago with Dr. Salem and Dr. Kunstman, and doing really well now. EUS is extremely sensitive to find a small, tiny mass like this. And this is another patient I want to point out to you. This patient had acute pancreatitis, just inflammation of pancreas, first time in his lifetime. And he was told that it is from alcohol. And his wife was pretty smart, and she didn't believe that. And she came to us, and we did further workup. Workup includes ultrasound endoscopy. And as you can see right here, again, very small mass blocking the pancreas duct. And that's what causing pancreatitis for him. And this patient also had a really good treatment since then. This is a different patient. You can see that this is the CT scan. This is the mass right here in the head of pancreas. And this particular patient had jaundice, really yellow discoloration all over. And we did ultrasound endoscopy. We found a really significant size mass right here. It's a pretty big mass here. And we biopsied that mass, also doing ERCP to treat the jaundice. And this is the ERCP picture. As you can see, we're injecting dye in the bile duct. In the bottom part, the distal part of the bile duct is narrowed down markedly, so you don't see a dye there. So this patient got a stent placed. And then after that, interestingly, the biopsy showed no cancer. So we have multidisciplinary conference where all of us, we sit together. And like Dr. Lacy mentioned, we have speed dial. We all of us talk each other on real time, and we text each other about patients, and found to have no cancer at all. This was an autoimmune condition which exactly looks like cancer. And you can imagine the anxiety patients might have having this kind of CT scan picture, but did really well with just steroids alone and got cured. So the pancreatic cancer sometimes may mimic certain other conditions which are really not cancer, but endoscopic ultrasound is a very useful tool. We can pinpoint what exactly it is, whether it's cancer or not. ERCP is endoscopic retrograde cholangiopancreatography. This is a very good tool to help for patients who have jaundice. As you can see in this cartoon, the bile duct is a green color here. This tube comes through the pancreas head and then drains into the small bowel right here. If someone has a tumor in the pancreas, it can block the pancreas duct, and also it can block the bile duct. So this black tube, the endoscope, goes all the way down. And then from there, we enter into the bile duct and we place stents like what you see here. We have different type of stents. Stents are small tubes which can drain the bile if it's blocked up. We have metal stents and plastic stents, like how you can see. Metal stents, we have different type of metal stents. One, we can leave it permanently, and other metal stents, we can take it out after a while. And this cartoon, you can see there's a metal stent going through the bile duct across the pancreas. And this is how the ERCP is done to help jaundice. This is a patient with jaundice, yellow discoloration. That's the initial presenting symptom. So the patient had a CT scan, found a small mass. So we did ultrasound endoscopy. As you can see, this is the mass right here. It's almost an inch size, but it is compressing the bile duct opening here. This is the bile duct is blocked. So this patient had a biopsy, and we diagnosed pancreatic cancer immediately on a real time using the technique I showed you. It's called ROSE. And then same time, under same sedation, patient had this ERCP for stenting across the bile duct. You can see that this part of the bile duct is not filling with the dye, and then you can see a lot of dye in proximal upper part of the bile duct. And we placed a metal stent, as you can see in this last picture. And once the stent goes in, the bile drains like how you can see right here. And that really helps to relieve the jaundice, and also helps the patient to get a chemotherapy so that the bilirubin comes down. As the bile duct gets blocked, and also the stomach outlet also can get blocked. In this cartoon, you can see how the stomach empties into the duodenum right here, and this is the pancreas right here. If someone has a tumor at the head of pancreas, if the tumor keeps growing, it can narrow down the duodenum and cause gastric outlet obstruction. And how we manage that with minimally invasive endoscopic technique is we have same kind of stents in a larger size. You can see that this soft mesh metal tubes, very soft, you can see in this picture. So the endoscope goes through that narrowing, and then we place the stent across that narrowing that opens up and really helps with nausea, vomiting, and patients can start eating again. And this is how it looks once the stent goes inside on X-ray. And this picture, we are looking from the stomach with the enteral duodenal stent in place. We have a new technique called EUS guided gastrojejunostomy. So this picture, you can see if the stomach is blocked right here with the mass, then the food cannot go through the duodenum right here. And what traditionally we used to do, if someone is not getting an enteral stent, Dr. Kunzman will do a surgical gastrojejunostomy, connecting the jejunum, that is small bowel, to the stomach directly like this, so that food can go through like this. This is a very good technique, very durable, and we have new techniques under EUS guidance. So with ultrasound endoscopy from the stomach, here you find a target of the small bowel, and then use a stent like this stent to connect the stomach directly to the small bowel, bypassing the blockage right here. So this is again minimally invasive and done as an outpatient basis to relieve the gastric outlet obstruction. Moving on to pain. Pain is one of the dreadful symptoms for pancreatic cancer. Sometimes it could be unbearable, and patients go on narcotic medication. Often there are limitations how much we can use, because narcotic medications have side effects too. We have this technique called celiac plexus neurolysis, also celiac plexus block. So what we do is, with ultrasound endoscope, we find the nerves and the ganglion which supplies the pancreas, as you can see here, through the stomach wall. And then once we identify that and we pass a needle through the stomach wall, the needle looks like that. And then we inject some medications like alcohol and numbing medication like bupivacaine right into the nerve ganglia. So what you're literally doing is you're destroying the nerves right here, so that you don't perceive pain because of destruction of the actual neural tissue there. Overall efficacy varies patients to patient, but most often 60 to 70% efficacious, at least in 1 or 2 weeks, and sometimes you may need another injection after 3 or 4 months one more time. And many patients go to radiation therapy. Stereotactic radiation therapy allows delivery of radiation with a high precision to the exact mass alone, while minimizing radiation to surrounding structures. EUS helps really to visualize the pancreas. As I showed you, even we can see the mass less than 1 centimeter in size. So what we do is, as you can see in this is the needle here. We have a gold pellet, gold fiducials, like a small, tiny metal piece. These are made of gold, which are very inert. So we find the mass in the pancreas and then place this gold pellet inside the mass, so that when the patient goes for radiation therapy like that under a CT scan, they can really see where exactly that gold fiducials are, and radiation can be precisely targeted exactly to that point and not outside. And this again we do on a routine basis in collaboration with our radiation oncologist and oncologist. Again, this is a painless procedure, outpatient basis. It takes around 30 to 40 minutes time to do this. Bile duct drainage, we spoke about ERCPs, but sometimes, as you can see, if to do ERCP, the endoscope need to get down all the way to the bile duct right here. Often, sometimes it's not possible, because if someone has a tumor right here like this, then the endoscope can't reach the bile duct opening right here. So traditionally, what we used to do is ask our radiology colleagues to go through the skin and drain the bile through the skin outside using a bag. And even today, that's one of the commonest procedure done in many parts of the country, in many institutions. But we have a special technique with ultrasound endoscope again, where we cannot get inside the duodenum, but still we can drain the bile duct directly through a special stent like this into the stomach, so that patients can avoid a bag outside. External drainage could be really cumbersome, bringing down the quality of life. So this technique really helps that. And similarly, sometimes patients develop cholecystitis, that is inflammation of gallbladder. As you can see in this picture, typically we drain the gallbladder through the drain outside in a bag like this. Unless patients are surgical candidate, often not, because of cancer and metastasis. So most often they have a bag and the external drainage. But with new techniques with endoscopy, we try to connect the gallbladder directly into the duodenum internally, like what you see in this cartoon. And then we have a stent which really helps to the stent really helps to connect the gallbladder into the duodenum and drain the bile internally so that one can avoid external drainage. In this short video clip, you can again see how the stent goes into the gallbladder, and we are pulling the stent into the duodenum or stomach and then deploying the stent in the stomach so the gallbladder drains internally. And this is really a permanent solution, and again done as an outpatient and painless procedure too. Novel therapies are available with the US guidance, and paclitaxel, like Dr. Persico pointed out, paclitaxel is still under trials, injecting this medication directly into the tumor and injecting alcohol to destroy the tumor. These are all under clinical trials now. Using a radio frequency needle, what we do is we try to go into the mass, pancreatic mass, if someone is not operable, and if we want to shrink the mass, so this needle goes into the pancreas mass, and then using a heat, it's almost like a cooking of the tissue, and that causes destruction of the tissue. And then it's been shown in certain tumors like neuroendocrine tumors and insulinomas to really shrink the tumor much and give a good prognosis for quite a while, because as you can see in this data. This is commercially available, and we started doing that at Yale now. And not only all this bile duct obstruction, duodenal obstruction, patients sometimes have blockage in the veins. As you can see here, these are the blood vessels just behind the pancreas. If the mass is blocking that vein, the blood supply can get blocked. So it gets backed up, and backed up blood can go into collaterals, different route, and that causes what is called as varices. And sometimes that can pop open and bleed. We have endoscopic techniques. So what we do is we go through the stomach wall, find where that engorged, bulging varices are, and we inject glue and coil directly into those varices, and that obliterates the blood vessels and stops bleeding or prevents bleeding. And technical success are very good with this kind of procedures. There are quite a lot of different procedures with endoscopy to prevent bleeding or treat bleeding. I just want to point out one or two procedures so that you get an idea about what minimally invasive options we have. This is a liquid nitrogen using a spray cryotherapy. Sometimes the tumor site can bleed, and then we can really help by injecting liquid nitrogen with some high pressure air that stops the bleeding right away. With that, I'll stop because I want to limit the time. And this is my partners, Dr. Priya Jamidar, Harriet Laney, James Farrell, myself, and Anil Nagar. We do all the novel endoscopic techniques and complex endoscopy techniques, and also simple regular upper endoscopy and colonoscopies. Happy to collaborate with Smilow Cancer Center, and happy to take care of you.
Great, thanks, Thiru. That was really a fantastic review of what I would say are remarkable advances in endoscopic procedures over the last several years that are really making a difference not only in diagnosis, but managing some of the complications which can be life-threatening in the management of these patients. So very much a part of the incremental progress that we're seeing. In the interest of time, I think we're just going to continue on. Please put any questions that you have in the Q&A or chat. We've had a few. We'll try to answer them in real time, and depending on how the time goes, circle back to some of them at the end. So next up, I'm really delighted to introduce our next panelist, Dr. Jacquelyne Gaddy. Dr. Gaddy recently joined a Smilow Cancer Center and Yale School of Medicine from the University of North Carolina this past year. She is a medical oncologist, also focused on GI cancer, pancreas cancer, and is an assistant professor in the Department of Medicine, Medical Oncology, seeing patients both in North Haven and in New Haven. Dr. Gaddy has dedicated much, if not most, of her training and career focused on improving cancer care delivery and outcomes for minorities and disadvantaged patients. And this has been through her research that she has conducted in health equity and through education efforts. So we're really happy to have you here tonight, Dr. Gaddy, and I will let you take the floor. Oh, and her topic, not surprisingly, is racial and ethnic disparities in pancreatic cancer.
Thank you so much, Dr. Lacy. As Dr. Lacy said, I have recently just joined the faculty here at Yale. I'm originally from Buffalo, and I thank all of you who have joined us this evening. I would be remiss if I did not start here, because this story that I am going to share with you really defines my career, my passion, and the care that I provide for my current and future patients. This picture here is my grandmother and I at my white coat ceremony in medical school, so probably almost a little bit over a decade ago for me. And my grandmother was, she was a sister to 11 other siblings, and she was a grandmother to 9 grandchildren, including myself. She was the matriarch of our family. And 7 years ago, almost to the day, my grandmother passed away from metastatic pancreatic cancer. And I share this story with you because it's extremely relevant to my passion in pancreatic cancer and also my passion with my research in health equity. Prior to my grandmother's diagnosis, she had been complaining to her primary care doctor for some months that she had some of the symptoms that were discussed this evening. She had new onset belly pain, that she called it. Her appetite had decreased remarkably, and my family had noticed she had lost a lot of weight. And my grandmother, a woman from the South, a woman born in the 20s, she was not one to complain. So this was something extremely serious. And months went by, and her primary care doctor did maybe a few things, few labs here and there, but ultimately time just went by. And it progressed to the point that she was having extreme pain. We called her primary care doctor, and he said he could get her in a couple of weeks. So that prompted my family to get her in with a new primary care doctor, who in fact did do a thorough workup. And at that time, he discovered my grandmother was with metastatic pancreatic cancer that had spread to her liver. And I share that story because my grandmother, she did speak up. She did try to tell that something was going on, and her complaints, unfortunately, had fallen on deaf ears. My grandmother is not the only person to share this story. I'm sharing 2 quotes today. One of them is actually from my aunt. She said to me earlier this week, "I think COVID provided proof of the disparate treatment between Black and white patients. It begins with a crucial patient-doctor relationship. Doctors can be quick to dismiss patient complaints." And the second quote actually comes from a patient that I had when I was in fellowship. And this patient stood out to me because she had the same exact birth date as my grandmother, May 16th. And she had the same story as my grandmother. She had been telling her primary care doctor, something's not right. I'm having a lot of pain, I'm not eating, and I'm losing a lot of weight. And again, months went by, and ultimately she was diagnosed with metastatic pancreatic cancer. It was far too late, and she succumbed to her illness within approximately a month of me meeting her. So for me and many on this call, health disparities is a known definition, but I think it's really important to define what in fact are health disparities. I'm sharing this slide from a provider from Johns Hopkins who defined this very eloquently. Health disparities are defined as preventable, and I think that's the most important word here, differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. And the goal, which is what my research focuses on and what ultimately my care delivery as well focuses on, is health equity, which is defined as every person has the opportunity to attain his or her full health potential. And no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. So what that means is regardless of your race, your socioeconomic status, and any other thing that we kind of define here in society, you still receive the same care. Dr. Lacy and I actually were having brief dialogue earlier this week, and we were talking briefly about the fact that, unfortunately, unlike other cancers, pancreatic cancer has not made as many advances as far as treatment, and that really leads to poor outcomes for many of our patients. But despite that, we know that there are still disparities seen within pancreatic cancer outcomes. This graph, and I try not to be too complicated, but the graph essentially is showing in the blue line, which are denoted as white patients, they are having a higher survival. So the graph, any of the lines that are higher, that shows that they're ultimately doing better than those patients that are beneath them, and Black patients being the marked red line closer towards the bottom. So something is still going on, that there is in fact health disparities. Recently, actually earlier this week on Twitter, someone posted this article, which was published earlier this year in April, which shows it's not just Black patients that suffer from significant racial ethnic disparities in pancreatic cancer treatment. What we are seeing, and which I'm highlighting, is that patients that are minoritized in communities, such as Native Americans, they also are experiencing significant racial ethnic disparities as well. So what is happening? This is really, this slide, which I adapted or was adapted from NCI, it shows a lot of the things that happen that ultimately lead to these disparate outcomes that I'm describing from my patient, my grandmother, and honestly, so many other people. And there's so many healthcare barriers that patients experience before they get to our doors. And they're highlighted here. Some of the times they're language barriers where there are not translator services available and symptoms are being missed. Other times it's transportation, meaning that the patient did not have a way to actually get to their visit, or public transportation is not accessible or feasible for their community. Other patients, they can't take off a day of work. If they miss a day of work, they're not going to get paid. Or in fact, they have a child at home that they don't have anyone to watch their child, and they can't afford childcare. And all of these things oftentimes combined together for many patients lead to some of the outcomes that I am describing. And this is just a known fact. And unfortunately, this is not just pancreatic cancer. If we look at other cancers, actually, it's a little bit more pronounced in other cancers, such as colon cancer screening. Another significant disparity that we see, and I'll highlight in just a little bit, is clinical trial participation. Clinical trials, which has been discussed here tonight, is really a significant component for advancing cancer treatment overall. And unfortunately, we see that clinical trial participation is not equal, meaning that oftentimes Black patients, while they succumb to these illnesses similar to their other counterparts, they're not being invited on trials and they're not being represented, which is actually shown here in the top right in this pie chart. So I want to advocate, and I want to say, so what can you do? And I think that's maybe why some of you are here this evening. I really encourage you, if you don't have a primary care doctor, to have a primary care doctor that you feel comfortable with, that you feel that listens to you, and maintain your routine primary care visits. Openly discuss symptoms. If something just does not seem like it's a normal day-to-day experience for you, tell them. Also, as I mentioned, try your hardest to self-advocate and encourage others, whether it's your relative, child, et cetera, to advocate for you as well. And also inquire about cancer clinical trials. I think more importantly, because a lot of this falls on us as physicians, so what can we do? I think it's really important. The moment before I walk into a patient's room, regardless of what is happening that day, I make sure that I'm focusing on my patient. So listening carefully, acknowledging the fact that there's cultural barriers and there's implicit biases that we all experience. Address underlying social determinants of health. And what that means is it really can't just be the cancer, because it's other things that are going on as far as transportation and other financial issues, as I mentioned earlier. And ultimately striving for equitable cancer care delivery, meaning that every patient, regardless of what they look like, they speak like, or dress like, that they're receiving the same level of care. And I think one of the things that my research focuses on is actually engaging with the community, going into the community and determining what are the barriers that are preventing patients from having the same level of care. This quote, which is actually from the article that I shared earlier in the beginning of my presentation, I think it's really important to just read it out loud. And it says, "It is clear that with sufficient collaborative effort and community outreach, progress can be made in addressing healthcare disparities." And here it's talking about Native Americans and Alaska Natives, but this can be any other minoritized community as well. It is our hope that the same strategies and infrastructure used to address the SARS-CoV pandemic can be replicated for future efforts to address the significant disparities that existed within this population, along with other minoritized populations, for pancreatic cancer and its research, as well as for other lethal malignancies. So what are we doing? So actually, Dr. Coons and myself, we are actually starting a particular cancer project where we are piloting this project within the community. And we're going into the community and we're discussing with patients and their families, what are some of the perceived barriers that they feel are limiting equitable care and also specifically limiting their access to clinical trials. This research will essentially focus on what is the underlying knowledge of clinical trials, meaning, is there any understanding of them? Are there any misconceptions of them? And then ultimately from that, being able to co-develop. So within the community, going into the community and discussing with community members how we can actually strive to educate and overall improve cancer clinical trial accrual so that it is more equitable. This picture is often used, and I think it really, really stands out because on the left, we see that's what quote unquote equality is. Okay, we're gonna give everybody the same box, but it's very clear sometimes people need a couple more boxes so they ultimately can have the same level of outcome and adhere the same view. So there is hope. And I think the hope will be continued drug development through clinical trials, improving clinical trial access, as I just mentioned, engaging with the community, and also strengthening workforce diversity. Thank you. Jill, you're muted, Dr. Mute.
Start again. Thanks, Jackie. That was really a fantastic overview of such an important topic, and we just need to continue the dialogue and the awareness. So again, trying to stay on schedule a little bit, we'll go to our last panelist, speaker, definitely not least, Dr. John Kunstman. So Dr. Kunstman is an oncologic surgeon. He also is a very integral part of our pancreatic cancer program here at Smilow. I have the good fortune of literally working side by side with Dr. Kunstman on Thursday mornings at our multidisciplinary clinic for pancreatic cancer, which is truly a privilege. John is an assistant professor of surgery in the oncology division. He has a very active, well, he's very active in the operating room, but also has a very active research program focused on pancreatic neoplasia. And as a surgeon, Dr. Kunstman tonight will be speaking on surgery for pancreatic cancer, what do patients need to know in 2022.
Well, thanks for that warm introduction, Jill. Certainly, it's my privilege whenever we work together. You teach me so much as well. Let me get myself here. Can everybody see my slides in the correct view?
Yes.
Yeah, okay, good. So thanks to everybody for coming and listening to the talks tonight. I think we had a great panel so far, and thanks to everybody that stuck around for the end. Again, I'll try and stay on time so we can have some time for questions and be respectful of everybody's evening. But I'm going to be talking, as Dr. Lacy said, about surgery for pancreas cancer. And really, I want to try and go over a fairly brief overview of both the history and what are the indications for surgery, what patients are appropriate for surgery, and how does that look from a patient point of view. But I want to start with a case report. And And this may seem familiar to some patients if they are on this call, or family members may recognize this, but this particular case was in a 60-year-old female. She presented to New York Hospital with a 10-week history of weight loss and jaundice, which we've heard about tonight, and a mass was felt in the upper abdomen. She was actually taken immediately for exploratory surgery. And at the time of that operation, there was a tumor or mass that was found in the head of the pancreas. The bile duct and the gallbladder was noted to be extremely distended. And the surgeon performed a bypass from the gallbladder into the stomach, and as well as a bypass from the bowel into the stomach. The patient actually did very well from this. In a 3-week period, she recovered, was eating again, the jaundice went away, was feeling much better. And so she was taken back to the operating room for a new operation where the pancreas head and the tumor that was associated with it was removed, as well as the first part of the bowel called the duodenum and the bile duct itself. And the pancreas was reconstructed by reattaching it to the bowel. So this was in 1934 on May the 7th by a physician named Alan Oldfather Whipple. And yes, that was his real name. And he just performed the first operation for pancreatic cancer to remove the head of the pancreas that bore his name. We still call a Whipple procedure these days, also called a pancreaticoduodenectomy. Unfortunately, the patient passed away very quickly, only 36 hours after surgery. So what happened? And why is pancreas surgery so difficult? Why is it something that's considered really a subspecialty? And why is it relevant to pancreatic cancer? Well, as you can see in some of these diagrams here, the one on the top is a view from the front. Let's see if you can see my pointer. You know, the pancreas is sitting here in the back of the body. Here's a cross-sectional view where the pancreas is outlined in green. You can see it's really surrounded by a lot of other organs. It's very intimately related to critical blood vessels and other structures in the body that need to be preserved. And so it's a very difficult organ to operate on. Moreover, those blocked bile ducts that patient had, either from tumor or from the course of an operation, can be deadly, as well as secretions from the pancreas can be deadly when those things are uncontrolled or consistently blocked, which is why that 2-stage procedure was originally developed. After that, because the thought was perhaps that reconstruction was what led to the patient's demise, the pancreas reconnection was actually abandoned initially in that operation. And the second and third patients that underwent that operation actually survived. However, the stage was set, but the problem was these complications, and the incomplete understanding of pancreatic cancer and how to manage those complications led to slow adoption of this procedure. It was, however, adopted at Yale quite early, within a few years of that initial operation. These two surgeons here, Dr. Harvey, Dr. Otterson, Dr. Harvey was the chair of surgery at Yale for many years, started operating on pancreatic cancer in 1941. And the first 2 patients that underwent the surgery in 1941 both survived the operation. And the main contribution from Yale and these 2 surgeons was that they, number one, advocated very strongly for a single-stage operation, which sort of set the stage for how we do the surgery today. Also, they very strongly advocated that the pancreas needed to be reconnected to the bowels to reestablish normal digestion, normal physiology. And those 2 important observations really set the stage for pancreatic cancer surgery to enter into the mainstream. And by 1945 or so, the operation actually took on what's essentially its present form. It's shown in this schematic that was drawn by a particularly artistic resident in a patient's chart many, many years ago. So we've been talking about the Whipple procedure in particular, and like I said, it's also called a pancreaticoduodenectomy. There are many different procedures that are done surgically on the pancreas or endoscopically, as Dr. Muniraj was referring to. But for pancreas cancer, they largely fall into 2 broad categories of surgery that's dictated by the anatomy of the pancreas. Again, the organ itself sits transversely in the back of the abdominal cavity area called the retroperitoneum. And as you can see on this schematic, there's really sort of 2 halves to the pancreas that we define by the relationship to those major blood vessels underneath it. And selecting a surgical approach is really paramount to where the tumor is located in the pancreas. For tumors that are located in the head of the pancreas, as it was in that case report, that pancreaticoduodenectomy or Whipple procedure is the preferred operation. But for tumors in the left side of the pancreas, a distal pancreatectomy with the spleen also being removed because of the proximity to the organ is the preferred operation. The other considerations are the need for lymph node removal and the involvement of any surrounding organs or blood vessels, and whether those need to be operated on or removed in order to successfully get the tumor out of there. So why do we even bother with surgery for this aggressive cancer, as Dr. Lacy was referring to? So does surgery actually improve survival for patients with pancreas cancer? Now, there's a large amount of data that really conclusively tells us that the answer is yes. However, both of those operations I was just describing are major surgeries. And you've heard from other panelists how important it is for patients that don't have metastatic disease to ideally get to an operation. I think the simplest way to convey that, though, is by talking about this small trial. It was done in Japan nearly 20 years ago. This study, which, by the way, would never be allowed to be performed in the United States, though, gave us actually really important information. So this study was on 42 patients who had a pancreas cancer that was proven resectable. All these patients went for an operation, and of those 20 patients that were randomized to resection, the operation was completed, the tumor was removed. The other patients, the operation was terminated, and they received chemotherapy and radiation therapy. Now, like I said, that trial would never be done these days, but it showed very quickly that it doubled survival for patients that had a successful operation compared to no operation for their cancer. And so the trial was closed because it was clear that surgery was beneficial. So the take-home point of that is that for patients without metastatic disease, surgical resection should really be the goal if it's possible for those patients. Now, what are the goals of surgery for patients that we think might benefit from it? Well, we want to maximize local control. That means taking the tumor out, ideally with negative margins, which I think Dr. Persico mentioned we call an R0 resection. We also want to remove those lymph nodes that are in the area of the pancreas where the tumor is, because oftentimes that's the first spot where the pancreas cancer likes to spread. So we remove those both for therapeutic purposes and also to better stage the patient to understand how their prognosis will be down the line. As Dr. Muniraj was alluding to, the cancer itself can cause blockages of the bile ducts, the bowels, and other things, discomfort, etc. So also by removing the cancer, we try to improve patients' quality of life, which oftentimes that improvement is quite remarkable. And of course, as in any other surgery, we want to minimize complications that could arise from the operation. So those are the main goals of an operation. Going back to that schematic that was drawn by that resident surgeon so many years ago, I don't know if everybody saw this up here in the corner, the date that this was drawn. This was in November of 1947. That is a long time ago. As I said, the operation schematically is very similar, but again, this was many, many years ago. So, when I found this note and took this picture, I was thinking, what else was going on in 1947? Well, I'm from Wisconsin, and I think kickoff is in about 10 minutes or so, but the Packers, my beloved Packers, went 6-5-1 that year. They're actually being coached by Curly Lambeau still, who is the namesake of Lambeau Field. Here in Connecticut, the Ingersoll Watch Company, which is now called Timex, launched their Mickey Mouse watch, which was the hot Christmas present of the year. Now, that was, again, 1947. Has anything changed with pancreatic surgery? Even just 20 or 30 years ago, all of these adjuncts, multiple drains, both internal and external, nasogastric tubes, operative drains, ostomies, feeding tubes, these were routinely used in nearly every pancreatic surgery. Gradually over time, the surgery was streamlined, outcomes improved. For instance, operative mortality just a few decades ago was 15 to 20%. That's mortality. In other words, patients that underwent the operation, nearly 1 in 5 or more might have died as a result of the surgery. These days, it's considered acceptable to have a mortality rate in the 3 to 4% range nationally. Here at Yale New Haven, our mortality rate over the last 10 years for this operation is 1.9%, so substantially better than the national average. Also, it was very routine for lengths of stay after this operation to be a month or more, sometimes many months in the hospital. Nationally, again, that's improved in the last 10 years or so. Here again, we're a little bit better than the national average. 7.7 days our average length of stay over the past 10 years, but complications can still be problematic. We do see serious complications in up to 10 to 20% of patients that have that surgery. And I just want to focus on these two complications here, both delayed gastric emptying and pancreatic fistula, because they can really slow patients' recovery and be particularly bothersome. delayed gastric emptying results in insertion or reinsertion of that nasogastric tube that patients and surgeons hate, and prevent patients from resuming their diet, sometimes for a prolonged period of time. And pancreatic fistulas is leakage of that pancreatic juice, which we see routinely early in the postoperative course, but when it's prolonged, it can really delay patients' recovery. So, again, here at Yale, as alluded to in every talk, research is a focus, improvement is a focus. So looking at those two complications, what have we done to contribute here at Yale? So we actually noticed, looking at our data, that we felt delayed gastric emptying was perhaps overly diagnosed aggressively and managed aggressively, perhaps too strongly. And we felt really that the majority of patients undergoing a Whipple procedure could forego that nasogastric tube that patients hate so much. So we designed a trial where we looked at 250 patients consecutively that underwent this operation. And half of them were in what we call the routine group, where, as is the traditional way to do the operation, the nasal tube was inserted in everybody, and the other half had a selective insertion. And in those two groups, we found there was no difference in the number of patients that needed the tube reinserted after surgery. And if we looked overall, the time with the tube was the same between the groups, but the number of days to the patients resuming their diet, their regular diet, solid food, and the days to discharge were drastically lowered by undergoing the selective nasogastric tube placement. So really what we found is about 85% of patients could undergo this procedure. And again, historically, it was 100% of patients needed this nasogastric tube, sometimes for days or weeks. 85% of patients, it could be cut out completely. Looking at operative drains, which have to do with that pancreatic fistula complication, most surgeons would routinely place one or sometimes several drains after this particular operation. We knew that it wasn't necessary based on our own data here at Yale for every single patient, but it was important to both detect and mitigate those fistulas when they happen. The problem was existing studies were really confusing. Here is a study from Memorial Sloan Kettering that basically said drains don't need to be used. They shouldn't be mandatory or standard after pancreatic resections. Well, here's a study that was done immediately thereafter from the University of Texas that said, if you don't put a drain in, you're actually hurting the patient drastically. So this was the state of knowledge, and to be honest, still kind of is, where there's all this conflicting data. So we thought, what can we do here at Yale, where we do a lot of these operations with good outcomes and try and be a little more thoughtful about it? We knew that selective drain placement was safe and effective from our good outcomes here in patients that didn't necessarily have drains. So we hypothesized that maybe we could use a marker or something in the blood that could tell us whether a patient was going to develop a fistula. We investigated a lot of different markers. Without going into the details, we found that one particular serum marker called C-reactive protein was really indicative of who was going to get this complication and who was not. And so again, we designed a trial, this one with a single arm, that really showed that with this marker, as well as our drain fluid amylase measurements, we could predict who was going to get this complication with a great degree of accuracy. And therefore, we would know who to need an early scan and early intervention, and who we could get that drain out. And again, that shortens the time to discharge, gets patients recovered more quickly, avoids those complications sometimes completely. So in 2022, what to expect if you're undergoing a Whipple procedure? And I'll talk about that distal pancreatectomy in just a second. Before surgery, as some of my colleagues mentioned tonight, you'll get CAT scans, sometimes several times over, especially if you get chemotherapy before surgery. You'll get lab tests with tumor markers. In some cases, we perform a small surgery beforehand using a camera called a diagnostic laparoscopy to try and better stage your cancer. And in most cases these days, there's a role for endoscopy, at least for diagnosis, and sometimes for management of some of those other things like jaundice, as Dr. Muniraj was talking about. On the day of surgery, at Yale at least, you will be the primary case of the day. I think some people know, even from reading just the New York Times, that you don't want to have your operation, your major operation, start at 4 o'clock in the afternoon. You want a fresh team, you want the A team, you want the number one focus of attention to be on you. And at Yale, that's the practice for patients that are getting a Whipple procedure. We use regional anesthesia with nerve blocks to decrease the amount of narcotic that you need routinely, both surgeon and anesthesia administered. We have a limited incision We at Yale, there are some centers in the region that perform a robotic pancreatic duodenectomy or laparoscopic approach, a small number of centers. Turns out the data for that is pretty soft. It doesn't really provide a benefit to patients, and it actually greatly lengthens both the operative time and costs. So I think there's a role for that in the future, but we here at Yale don't feel like it's ready for prime time right now. The typical length of the operation in our hands is about 5 or 6 hours, sometimes a little bit shorter, sometimes a little bit longer. After surgery, everybody goes to the ICU for monitoring on the first day, but following that, you're in a dedicated ward with a dedicated team and a dedicated set of nurses and residents that are taking care of patients that undergo these operations routinely. As I was alluding to, we don't put that nasogastric tube in most patients. Most patients are out of bed the very first day after surgery. Most patients are starting a diet, even if it's just sips of liquids on that very first day after surgery. And we use intelligent management to drive those complications and heading them off and management of the drains. The typical length of stay for an uncomplicated Whipple procedure at Yale is about 4 to 6 days. What about that distal pancreatectomy? Now, here's something where we do feel there's a substantial benefit to be gained from a minimally invasive approach. And about 80 to 90% of these operations are done here at Yale laparoscopically. You can see the incisions on a patient of mine on the abdomen. You can see the 4 incisions where we did the procedure through, quite limited in size. The typical length of this operation is about 3, sometimes 4 hours. After surgery for this operation, patients don't go to the intensive care unit. Again, same thing, dedicated ward, dedicated residents, dedicated nurses that are used to taking care of patients that need pancreatic surgery. Is it safe? In properly selected patients, the answer is yes. There's a strong relationship with pancreatic surgery and experience. Some surgeries, that relationship is really just having to do with the surgeon. For pancreatic surgery, it's different. I think you can see from our multidisciplinary panel, it's a multidisciplinary disease managing pancreatic cancer. And it turns out that for pancreatic surgery, the most important thing apart from your surgeon is how many operations are done in the hospital itself. You can see here's graphs that are showing mortality for this operation based on number of cases done both in the hospital and in the individual surgeon. And you can see how much of a difference that makes to have more experience both of the surgeon and the hospital. It's so interesting to see in this particular study, they considered a high volume surgeon an individual that did 4 pancreatic surgery cases per year, 4 cases per year. Here at Yale, over the last 5 years, when I last updated this slide, and the 5-year span from 2014 to 2019, the numbers actually are higher now. We did 420 pancreatic resections. That works out to 84 cases per year. And it's split up between 4 surgeons, and really just 2 or 3 of them do the majority of the cases. So you can see our numbers here are very, very high compared to most institutions. So what comes next? I want to move along and leave time for questions, but what comes next? So as I think is a strong theme of all of our talks, research is important. We're working to define the timing of chemotherapy around resectable pancreas cancers. That term's been talked about a couple of cases through the talks tonight, but here's a CAT scan, which shows a cross-sectional image where we can see the pancreas is outlined here. Here's one of Dr. Muniraj's stents right there, opening up that bile duct. And this dark gray area here, I know it's all gray, but this particularly dark gray area is the tumor here in the pancreas. And what determines the resectability when there's no metastatic disease is the relationship to these blood vessels. Now, here's the origin of the mesenteric artery and the mesenteric vein. And you can see the tumor's close to, but not necessarily touching or invading either of those structures. So this is what we would call resectable disease. And it's still an open question about whether the right thing to do as a first treatment is to give this patient chemotherapy or take this patient straight to the operating room. And we're running a trial here to try and answer that question along with some of our peer institutions nationally. Some patients, though, they do have involvement of, in this case, again, here's the tumor, involvement of, in this case, the vein with the tumor. You can see here with this shadow here that the tumor is about 270 degrees around that particular vein. This is something we would call borderline resectable disease. In other words, it can come out still, but sometimes needs a little bit of a fancier approach in the operating room, and perhaps some shrinkage from Dr. Persico, Dr. Gaddy. Their treatments before surgery can sometimes render this tumor a bit smaller. There's a picture from the operating room that's coming up, so if anybody's a little squeamish, just close your eyes or cover the screen for a moment. In the operating room, the tumor is located here. I've got a cartoon here showing you where the tumor is in the head of the pancreas. And after we take it out, we can actually strip it off, that vein and the artery here, and repair those directly. You can see in this operating photograph in the lower part here where it says artery, that's the edge of that mesenteric artery, completely devoid of all those nerve tissues and lymphatic tissues that Dr. Lacy was alluding to in her earlier talk. And the vein has been completely cleared of tumor and repaired directly to allow us to remove those borderline cases. Now, sometimes we see what we call locally advanced, or sometimes termed unresectable disease like this, where the tumor completely occludes this vein. You can't even see it on this particular photograph, and can surround even the artery around here, which can make surgery very difficult. These patients definitely need chemotherapy at first, and they definitely sometimes benefit from radiation therapy as well. But occasionally, in the right selected patients, we can still take them to the operating room and remove it. Again, an OR photograph is coming up. If there's anybody a little squeamish, might want to turn off the monitor for a moment. But we do sometimes get these patients successfully to the operating room and remove their tumor. And here's a particular case where, again, you can see that artery, which is over here, completely devoid of the overlying tumor tissue. And in this case, the vein itself was completely removed, and we replaced it with a vein graft coming from a different part of the body to allow that resection of the tumor and reconstruction so that tumor can still be removed. There's a lot of things that I've skipped over in terms of what comes next. We talked about targeted agents, particularly for that KRAS gene, new combination therapies that are under trial here that Dr. Persico was alluding to. Local treatments for very limited metastatic disease in some patients that may qualify for that, very highly selected patients, and new surgical approaches, including more aggressive approaches to vascular resections and minimally invasive techniques. So with that, I'm going to stop. Ran a little bit over my time, so I'm sorry about that, but wanted to leave some time. These are my partners in surgical oncology. Not all of them do pancreatic surgery, but some of our research staff as well. And I hope it was informative. And again, certainly we'll stay on to answer any questions. So thanks again for the opportunity, and I'll stop sharing my screen.
Thanks, John. That was great. And again, I think you really nicely highlighted really the major advances in surgical technique that have clearly contributed to improvement in outcomes for our patients and overall survival. The hour is late, and we haven't had a lot of questions. So if anyone has a few burning questions, please put them in the chat. There was one question that came in earlier that I will address. Someone asked about molecular testing of the tumor in pancreas cancer. Do we do it in everybody? So I think, as Dr. Persico alluded to, it is recommended that all patients with this diagnosis have genetic testing. And by that, we mean testing of the DNA that they were born with from a blood test or a cheek swab to see if they carry a gene that's mutated that may have caused pancreas cancer. And the most common gene that we find in about 5% of patients is the BRCA BRCA1 or 2 gene, associated also with breast and ovarian and prostate cancer. And that's important in patients with advanced disease because they are candidates to get the targeted therapy olaparib, and it's important for their family members. Separate from that is DNA testing of the tumor itself. People refer to that as tumor profiling or molecular profiling or DNA analysis. It has a lot of different names, but extracting the DNA and looking for those mutations that contributed to this cancer. And most of the time we find lots of mutations, but we don't find mutations for which we have drugs, but occasionally we do. And again, Justin listed some of those, and it is very important to do that testing so you don't miss a target of opportunity in terms of treatment. We will try to do that on the biopsies that are often taken by Dr. Muniraj and his colleagues initially. Frequently, there's not enough tissue to do that, and then we can do what's called a liquid biopsy and do that type of analysis on DNA from the tumor that's found in the blood. That type of testing should be done on all patients with advanced incurable disease. It's a little less important for patients who have resectable curable disease because we don't need that information at that point in time. But in any patient with advanced incurable disease, we recommend that absolutely in all patients. So that was a really important question. So the hour is very late, and I want to thank our panelists for great talks tonight, and in particular, thank all of the participants who listened to the end. I know this is a very busy time of year heading into Thanksgiving and the holidays, so we really appreciate your attendance and attention. If you have questions, you can reach out to us. Most of us are pretty available, and we're happy to answer any questions. I know many of you are patients, family members, and advocates, and many of you are very active in advocacy, and I want to certainly thank you for your efforts there, because that really is very important. So again, not seeing any questions, so we'll let you get the rest of your night back. Thanks everyone so much. Great talks, and thank you to the audience for participating and coming this evening.